Good evening, Dr. Phil here. Today we'll be discussing on broad complex arrhythmias. The tachycardia algorithm with Pulse ERC 2015 has been discussed in detail in the video entitled Perioperative Arrhythmias Part 1. Kindly refer to that video for further details. Ventricular ectopics. Contraction of ventricular muscle caused by an ectopic focus instead of normal impulse conduction. It is frequently observed during anesthesia. Causes. It may occur in normal hearts. Other causes include organic heart disease such as myocardial ischemia, adrenergic stress such as due to hypoxemia, hypercapnia or pain, drugs such as halotane, digoxin and antiarrhythmic drugs, and electrolyte and acid-base disturbances. Mechanism. There is increased inward movement of calcium, resulting in a rise in the phase 4 slope. Non-conducting cells depolarize spontaneously and themselves act as pacemakers, and this results in premature beats. Ventricles discharge early, and the next sinus impulse finds the ventricular muscle refractory, causing a pause before the next beat. ECG shows irregular rhythm, with no associated P waves as PVCs results from ectopic pacemaker activity arising below the AV node. There are wide, more than 0.12 second, and bizarre QRS complexes because it originates in and spreads through the myocardium or ventricular conducting system. Ventricular ectopics arising from different sites may have different configurations. In patients without structural disease, ventricular ectopics are usually benign. However, in patients with ventricular disease, ventricular ectopics may occasionally herald the onset of runs of ventricular tachycardia. Management. A new onset PVC should be considered a potentially serious event as it may lead to ventricular tachycardia or fibrillation. Correct contributing causes. Ensure adequate oxygenation, normocapnia, and analgesia. IV atropine or glycopyrronium may be used if the underlying sinus rate is slow, less than 50 beats per minute, as the ectopics may be ventricular escape beats. IV lidocaine is recommended for ventricular ectopics of more than 5 per minute, or if multifocal or close to the preceding T wave, with risk of the R on T phenomenon. Ventricular tachycardia. Features. Ventricular tachycardia is a serious and potentially life-threatening arrhythmia that needs emergent treatment. In general, VT is said to occur when 3 or more sequential premature ventricular contractions are present. Regular rhythm at heart rates of 100 to 200 beats per minute. P waves may be seen if there is AV dissociation. Ratio of P and QRS has no fixed relationship because of atrioventricular dissociation. QRS is always wide. Fusion, capture beats, and atrioventricular dissociation may be seen. Normal atrial activity may continue independently, or the ventricular impulses may pass retrogradely into the atria. Monomorphic VT has an abrupt onset, regular ventricular rate, a rate above 100 beats per minute, usually 140 to 200 beats per minute, possibly some superimposed P waves, a wide QRS complex tachycardia. QRS complexes are uniform. Monomorphic VT rarely occurs in the absence of structural heart disease. Polymorphic VT, also known as Torsade points. ECG shows a heart rate of 150 to 250 beats per minute. Ventricular rhythm is irregular. There are multiple QRS morphologies. QRS complexes appears to be twisting around the isoelectric line of the ECG, and QT interval is prolonged. Polymorphic VT may be congenital or acquired. The latter is much more common. Monomorphic VT versus SVT. It can be difficult to distinguish monomorphic VT from a SVT with prolonged AV conduction. Both VT and SVT may be regular and associated with normal tension or hypotension. Features to suggest ventricular tachycardia rather than SVT. The QRS complexes are usually wide and bizarre in VT. Inverted P waves. Retrograde conduction to the atria may result in inverted P waves in VT, which may be hidden by QRS complexes. Independent atrial activity may be seen in VT, which is suggested by occasional P waves, capture beats, when normal QRS complexes following occasional normal atrioventricular conduction, and fusion beats, with combined features of normal and ectopic QRS complexes, representing simultaneous atrially conducted and ectopic ventricular activity. Fusion beats is produced by the retrograde transmission of a ventricular ectopic impulse that collides with a supraventricular impulse. A hybrid QRS complex is formed, which is a mixture of the normal QRS complex and the ventricular ectopic impulse. AV dissociation may be seen in VT rather than SVT, i.e. no fixed relationship between P waves and QRS complexes. This is more likely to be discovered on a 12-lead ECG rather than on a single lead tracing. P waves are most visible in the inferior limb leads and anterior precordial leads. In VT, there may be marked left axis deviation. Response to adenosine. Adenosine abruptly terminates most cases of paroxysmal SVT, but not ventricular tachycardia. Causes of VT includes, as for ventricular ectopic beats, such as myocardial ischemia, hypoxia, hypotension, fluid overload, electrolyte imbalance such as hypokalemia and hypomagnesemia, and catecholamines such as adrenaline. Management. Cardioversion if there are adverse signs such as hypotension, or when drugs are contraindicated or ineffective. If pulseless VT, treat as for VF, unsynchronized biphasic defibrillation 120 to 200 joules, or unsynchronized monophasic defibrillation 360 joules. Synchronization is unnecessary if VT is pulseless or very rapid. If there is evidence of hemodynamic compromise but pulse is still present, synchronized biphasic cardioversion regardless of whether the rhythm is VT or SVT with aberrant conduction. The energy of the initial shock should be according to the manufacturer's suggestion. If not available, maximum energy shocks should be considered. Biphasic energy 120 to 150 joules and monophasic energy 200 joule is typical. If the initial shock fails, increase the dose in a stepwise fashion. Unstable polymorphic irregular VT with or without a pulse, treat as VF using defibrillation doses, unsynchronized biphasic defibrillation 120 to 200 joules, or unsynchronized monophasic defibrillation 360 joules. Unstable monomorphic regular VT with a pulse, treat with either synchronized biphasic waveform cardioversion 120 to 150 joules, or synchronized monophasic cardioversion of 200 joules. If the initial shock fails, increase the dose in a stepwise fashion. Witnessed and monitored patient with VF or pulseless VT, where manual defibrillator is rapidly available, such as in catheter lab, coronary care unit or critical care area, 3 quick and successive stacked shocks is recommended. Chest compression is unlikely to improve the already very high chance of ROSC when defibrillation occurs early in the electrical phase, immediately after the onset of VF. If this initial 3-shock strategy is unsuccessful, the ALS algorithm should be followed and these 3 shocks are treated as the first single shock given. Adenosine if no hemodynamic compromise and the diagnosis of VT is uncertain, the response to adenosine can be helpful as it abruptly terminates most cases of paroxysmal SVT but not VT. Amiodarone is the favored drug for suppression of monomorphic VT. Amiodarone may be given to sustain sinus rhythm if the patient relapses into VT. The dose is 150 mg IV via a central venous catheter over 10 minutes, repeated if needed, followed by 900 mg over 23 hours, maximum 2.2 grams over 24 hours. Lidocaine may be given to sustain sinus rhythm if the patient relapses into VT. 100 mg IV bolus restores sinus rhythm in 30 to 40% of cases and may be followed by a maintenance infusion of 4 mg per minute for 30 minutes, then 2 mg per minute for 2 hours, followed by 1 mg per minute. Sotalol may be used if lidocaine fails. The dose is 100 mg IV over 5 minutes, which has been shown to be better than lidocaine for acute termination of VT. Cardiac pacing has also been used. Management of recurrent VT involves antiarrhythmic drugs, catheter ablation of the ectopic focus, and implantable defibrillators. Torsade depoints. Features. Torsade depoints is a polymorphic VT with QRS complexes twisting around the isoelectric line of an ECG. It is typically related to QT interval prolongation and the R on T phenomenon. Torsade depoints is usually invoked in the situation of prolonged QT interval or bradycardia, Drug-induced prolongation of ventricular repolarization is associated with Torsade points and sudden cardiac arrest. Check the baseline QT interval and check for drugs that prolong QT interval before operation, as prolongation of QT interval may increase the risk of Torsade points. Predisposing factors: electrolyte abnormalities such as hypomagnesemia, hypokalemia, and hypocalcemia, drugs such as antiarrhythmics, quinidine, disopyramide, procainamide, ibutylite, and sotalol, antimicrobials such as clarithromycin, erythromycin, and pentamidine, neuroleptics such as chlorpromazine, thioridazine, droperidol, and haloperidol, and other drugs such as granisetron, methadone, and cisapride. Monitoring measures used to check for the possibility of Torsade points includes the QT interval, the QT interval corrected with heart rate QTC, where QTC equals QT divided by square root of the RR interval. Normal QTC is 0.44 seconds or less. QTC of more than 0.5 seconds increases the risk of Torsade points. Other measures includes the JT interval, the QT dispersion QTD, QT variability index, and transmural dispersion of repolarization. Many anesthetic drugs may cause mild prolongation of the QT interval, but are not likely to cause Torsade points. All inhaled anesthetic agents prolong QTC and QTD. Sevoflurane does not affect TDR. Propofol does not significantly affect QTC. Opioids, most have not been associated with QTC prolongation, but a high dose of sufentanil may produce QT interval prolongation. Succinylcholine significantly prolongs the QT interval and QTC, particularly with thiopental. Non-depolarizing neuromuscular blockers, most have not been associated with QTC prolongation. Reversal agents: anticholine esterases with anticholinergics used to reverse neuromuscular blockade causes transient but significant prolongation of QTC. Sugammadex is relatively safe. Local anesthetic agents have no significant effects on QTC. However, the level of blockade can influence ECG. Antiemetics: droperidol can cause sudden potential cardiac death. Serotonin type 3 receptor antagonists such as granisetron and ondansetron are associated with prolonged QTC. Management of TDP: treatment of the predisposing condition. If hemodynamically unstable, non-synchronized electric cardioversion or defibrillation should be delivered promptly. IV magnesium sulfate 2 grams over 1 to 2 minutes followed by IVI 2 to 4 grams per hour is the first-line treatment if the patient has recurrent non-sustained episodes of Torsade points in the perioperative period. IV potassium: aim to increase serum potassium by 0.5 MEq per liter. Overdrive transvenous pacing is an treatment option with a target heart rate of 90 to 100 beats per minute. Isoprenaline is another treatment option to increase the heart rate. Class 1 antiarrhythmic drugs should be avoided. Ventricular fibrillation. Features: uncoordinated and ineffective ventricular contraction caused by completely irregular ventricular depolarization. VF may follow the R on T phenomenon. The R wave of a ventricular ectopic beat falls on the T wave of the preceding beat. At the middle of the T wave, the myocardium is partly depolarized and partly repolarized and thus vulnerable to establishment of reentrant and circulatory conduction, leading to VF or VT. VF is the most common cause of cardiac arrest. There is no cardiac output. Asystole therefore follows unless treated. ECG shows irregularly and grossly disorganized heart rate, totally irregular rhythm, no relationship between P and QRS complexes, and no QRS complexes can be identified. Causes: myocardial ischemia, hypoxia, electrocution, electrolyte imbalances, hypothermia, and drug toxicity such as due to adrenaline or digoxin, etc. Management: immediate non-synchronized defibrillation with 200 to 360 joules. Biphasic shock reduces the required energy level and increases the efficacy of defibrillation. Magnesium sulfate may facilitate defibrillation. Adrenaline can be used to caution fibrillation just before defibrillation. Immediate cardiopulmonary resuscitation. Supraventricular tachycardia with aberrant conduction. SVT may be brought complex under certain conditions. due to aberrant conduction between atria and ventricles. This may appear only at high heart rates due to rate-related aberrant conduction. SVT caused by an abnormal or accessory pathway, such as WPW syndrome, may be brought complex if conduction is anterograde in the accessory pathway, but normal width if conduction in the accessory pathway is retrograde. Management. All broad complex tachycardias should be treated as VT unless proven otherwise. Adenosine may be used diagnostically to slow AV conduction and may reveal the underlying rhythm in atrial flutter or atrial tachycardia, and adenosine may also result in conversion to sinus rhythm in a case of SVT. These are my references. Thank you.